So welcome back. Today we will be talking about psoriatic arthritis, and it was first described probably in the 1800s, but it really wasn't defined until the 1950s when a British physician by the name of Dr. Verna Wright described it as something separate than rheumatoid arthritis. And this is a case where the immune system is overactive the wrong way and it starts to attack the skin and the joints. And in particular, it actually eats away at the joints. It causes erosions. Now, psoriatic arthritis is a type of spondyloarthropathy, and this is a fancy way of saying that it is a type of autoimmune arthritis that affects the back or the spine. And there are other diseases also in this category, which is why psoriatic arthritis can be called axial, meaning mostly in the spine. It can be called peripheral in joints that are not part of the spine, such as the hands, the feet, the ankles, etc. Or it can be a combination of both. The symptoms of psoriatic arthritis is the psoriasis. So the psoriasis is a large red flaky rash that usually happens on the elbows or the front of the knees or the scalp, behind the ears, or even in the nails. The other thing this arthritis can do is it can give a lot of morning stiffness that actually gets better with activity. It can also give inflammatory back pain. So this is back pain that will actually wake the patient up in the middle of the night, and the only thing that really makes it go away is walking around for a little bit. These patients can also get dactylitis, where a whole finger or a whole toe looks swollen, like from across the room. It almost looks broken, but it is actually swollen. And in these patients, they can get what is called enthesitis, which is a fancy word for saying that the ropes that connect the bones to the bones, the ligaments, or the ropes that connect the muscle to the bones, the tendons, can get inflamed. So in this case, patients can get Achilles tendonitis. And also in these patients, because of the social isolation that occurs with the rashes and the joint stuff, the chronic pain, they can get a lot of depression and anxiety. Now, who gets psoriatic arthritis? Well, it is more common in those with psoriasis, and sometimes the psoriasis can happen with the joint inflammation. It can happen before the joint inflammation, or it can even happen after. But it is usually in patients who have had severe psoriasis that comes on suddenly and affects the nails. The other thing it can happen is that it can occur equally in men and women, but men get more axial disease. It's not as common as you would think, but it is still a common arthritis. It is less common than rheumatoid arthritis. So if you take the example of how many people do I need in a room for even one person to get this, I would need about 2,000 people in a room for maybe one person to get psoriatic arthritis. It does have a genetic part to it, meaning that those patients that have a relative or a first-degree relative that has psoriatic arthritis, their chances do increase. It does occur more in whites. It does occur more in patients about the age of 35 to 40, but it can happen at younger ages as well. And of course, there are risk factors for this disease, just like any other disease that irritates the immune system, such as smoking or obesity or alcohol abuse. Now, as far as the diagnosis of this arthritis is just like everything else in rheumatology, where you have to take what the patient is saying and match it up with what is happening on their body, and then use labs and tests if needed to confirm the diagnosis. So in this case, we are looking for psoriasis, that rash that actually gets better in the sunlight. We are looking for that dactylitis, that whole swollen finger or toe. We are looking for that inflammatory back pain that will wake the patient up in the middle of the night and cause them to walk around to try to get it to go away. We're looking for that significant morning stiffness, so it will last at least 30 minutes to an hour or more and gets better with activity. And then we are looking for that enthesitis, so that pain of the ligaments and the tendons, especially like the Achilles tendon. And then we are looking for nail changes. And in these patients, yes, on the inside, the inflammation markers can be high, and there is also a genetic marker, but it is not unique to this disease, meaning it is found in other diseases. And there are some people that have the genetic marker that never get this disease their whole life. So it's one of those that's kind of a hit or miss type of thing. And then also scans and x-rays, CT scans, etc., can actually show the joint being damaged. As far as the treatment of psoriatic arthritis, it really depends on what is happening with the patient and where it is happening. So, some people, there are medications that are better for the axial disease. There are some patients that's better for the peripheral disease. And then, of course, there's extra articular disease. So, this is disease that doesn't happen in the joint but happens outside of the joint. So, in this case, patients can get uveitis, which is inflammation of the water right behind the whites of the eyes. And in those patients, certain medications are better. Now, in these patients, the treatment is a little bit unique because if you give a psoriatic patient too much steroids, their skin rash can get a lot worse. It can actually become pustular, so it can become a lot worse. So in these patients, you try to avoid the high dose steroids or even the medium dose steroids. You try to do NSAIDs like ibuprofen and Tylenol, and then you also pick a steroid sparing agent pretty quickly. So again, these are medications that will push down the immune system, but without the steroid problems. And these patients, they do get more high cholesterol, so treating that hyperlipidemia. And then, of course, the mental health issues of this disease, so treating any depression or anxiety. Now, as far as the long term outlook for these patients, they do very well with treatment. But there are two things that have to be paid a little bit closer attention to. So, one is the metabolic syndrome, and these are diseases that can increase the risk of diabetes or heart disease, so actually can affect the patient's quality of life or even shorten it. So making sure to treat that hyperlipidemia, that hypertension, and that obesity. And then also the mental health portion, because as you can imagine, with rashes and with joint pain, these patients have chronic pain issues, but they also tend to have more anxiety and more depression. So making sure that is treated, because that can definitely affect the quality of life and can definitely shorten it as well. And then finally, in this disease, I tell my patients to always take a picture of any rash, even if they have it in this disease or not, but in any rash case, they should always take a picture, because sometimes these rashes will go away or sometimes they'll come suddenly, etc., in different parts of the body. So it's always best to show those pictures to your doctor by the time you get in to see them, because in this case, a picture really is worth 1,000 words. Until next time.